Thank you. You guys can see that okay?
Yeah, perfect.
Great. So to begin with, I'm just going to go back one slide here, actually. We often start off with articles of the week or reads of the week for ECHO IPH. And so I think this is a really important time frame. This session happens just the Friday after International Long COVID Awareness Day. And so I think there's two articles I really encourage you to read by two female physicians who are amazing experts and actually have like experience on long COVID as well. So there's one from last week from Manali Mukherjee, who's a respirologist at McMaster, who's a researcher as well as a respirologist and experience of long COVID. And a slightly older article from our own Jen here, actually, I think it's really worth reading, looking at the public health crisis and the effect it's having on women in particular at the height of their lives. So two articles for you to read and really keep in mind and reference back and share with others to increase awareness and understanding because it's meant for a larger audience. So our goal today is working on recognizing, supporting care for people with long COVID. The three of us will be sharing information together, recognizing a huge topic like this for a disorder that affects pretty much every body system can't be covered in 20 minutes. So we'll do an approach today, but you have references here to our older talks that we have. One is the YouTube video as well as the slide deck that really looks at the evidence around the research on which organ systems are damaged, what cognitive and neurological systems are affected, how after long COVID. And so you can dig through those at your time and for your own reference. So in terms of the disclosures, so these are the disclosures that I have. None of them are in conflict with the topic here. They relate to diabetes, work, or consulting on health system policy and research and mental health. For Megha, she didn't have any disclosures either to make. And Jen's disclosures relate to research grants and supports and educational efforts as well. So this is built on information that lots of people add to over time, including some people on this hub and people outside. And it's a learning effort from all disciplines, from researchers, from librarians, from specialists and family physicians and other disciplinary providers. We'll make sure that we're keeping things evidence-based wherever possible, but recognizing that long COVID is something that's really emerging, that information takes a while to be published and reach the stages that we need. So there's going to be off-label use of drugs repurposed for utilization and supported by evidence, and we'll make sure we highlight that to you as the options to offer to your patients and clients. Our goals are to recognize the prevalence and incidence of long COVID, because I think it's underappreciated, looking at the spectrum and severity of symptoms and signs, and looking at how we can prevent it, assess it, and manage it most effectively. So the names, obviously, you've heard many different names. Colloquially, we call it long COVID. It's got many different names and slightly different variations in definition. The WHO definition is post-COVID-19 condition. And that's very clear because it's not a syndrome. It does have a defined cause, which is COVID infection. We're understanding how the constellations of different disorders that branch an umbrella underneath post-COVID-19 condition work. People with long COVID may use names like long hauler COVID, and that's actually something that you'll hear a variety in this presentation as well. But if you don't have it ourselves, we want to make sure we're not stigmatizing or defining patients by a disorder alone. So like we do for diabetes, like we do for other conditions, we want to make sure we recognize the disorder as being a part of a person's life. So how many people does long COVID affect? And here we have updated information from StatsCan, which did a large study and has done every year since the pandemic began, looking at how things have changed in our population out there in Canada. So we know that as of last June, about 2/3 of Canadians had at least one confirmed COVID-19 infection. Many more obviously had unconfirmed or suspected diagnoses. And of the Canadians who had had one confirmed infection, 1/5 of them had actually more than one infection. And this is more common in certain racialized populations because of risk and exposure and inability to quarantine or protect themselves in the earlier stages in particular. So recognizing both COVID and long COVID definitely has an equity lens to it as well. To keep that in mind about how we actually are giving supports, making the diagnosis and getting to a more functional state. So the important thing to keep in mind for that second graph here is looking at with each subsequent round of COVID reinfection, we see higher rates of long COVID. So by the time you get to 3 or more infections in your history, more than 1/3 of people will have long COVID. And so you can recognize if you're not seeing that in your practice, then you would wonder how well is this being diagnosed? How often are we picking it up and not even considering it? So on average, we know that 1 in 9 Canadians have experienced symptoms of long COVID after an infection. And that's the general population out there based on StatsCan survey. The clinical population is going to be even higher because people who are well typically don't end up seeing clinicians as often. So it's going to be a much higher percentage of who's coming to your door. And of the people who have had symptoms, more than half have ongoing symptoms that haven't resolved. Though a significant portion do get better over time. We'll talk about that as well. So we know of the people who have long COVID, 10 to 30% were among those who were never hospitalized for COVID-19, though it's a much higher rate if you've had more severe COVID as well. But even if people have been vaccinated, about 10 to 15% can experience long COVID as well. So if we're looking at the incidence as well, because the majority of infections and exposures tend to be in people who are younger and active and out there in the world, we know that 90% of people seeking care for long COVID actually had mild long COVID and typically the age of 36 to 50. Women are a lot more likely to develop long COVID, and this number may be an underrepresentation. There may be many reasons, including autoimmune and other phenomena that are contributing to this condition as well. Children definitely also develop long COVID, and we've seen different research between the as low as 4.6%, as high as 25%. But most studies still look at it as being comparable to adults around the 10 to 20% range. And we'll talk about how that presents as well. So the Ontario COVID-19 Science Table estimates more than 250,000 excess primary care visits per year because of long COVID. And probably this number is an underestimate as well. And really important, the reason why we're having this talk where we all need to work so well together here is because 2/3 of Canadian adults who tried to get healthcare services for their long-term long COVID symptoms felt they didn't receive the care that they needed. And so there's a lot more that we need to do to meet the needs. If you're looking at the wider socioeconomic impact of long COVID, there's the 2024. So this year, Germany, a large study estimated that they entered a recession because of longer sick days that they attributed to long COVID in that study. So a significant 0.5% drop in GDP in that nation was attributed to this effect. StatsCan last year also looked at 24 lost days of school or work due to long COVID, and that's comparable to the impact that we see in the German cycle as well. The Quebec Health Minister identified that he felt that 10% of healthcare worker absences were due to long COVID last year, contributed to that health worker shortage as well in a more significant way. And lots of studies looking at labor worsening in the US and other jurisdictions also looked at about 10 to 15% effect of unfilled jobs due to disabilities or reduced abilities due to long COVID. In terms of the duration, so acute COVID, we define at 2 to 3 weeks. We don't call it officially long COVID typically until around 3 months or 12 weeks. But you can have symptoms beginning obviously much sooner than that, so we may not classify properly there. It's useful looking at the timeframes though. So this is a complicated slide, but really what I want you to pay attention to is that if symptoms are either getting more severe or more new numbers of symptoms are emerging 2 months after the COVID infection, that person is much more likely to have longer lasting durable symptoms, even up to a year or longer. So most patients have symptoms for more than 3 months, and up to a third of them have symptoms more than a year, and half of those still persist at 2 years. So you can see a pretty long duration of symptoms for many people. So the most important thing to recognize is COVID-19 is primarily a vascular virus. The lung effect is a secondary effect of its infection. By the time it actually gets to the lung, they've actually shown it gets to the brain and other organs at the same time because it spreads through the blood vessels. And so if you recognize that really wide distributed effect of COVID-19 infection, a lot of what you see in long COVID makes a lot of sense. So we think about in terms of what's causing long COVID after the acute infection hopefully is resolved, there may be viral persistence. And reactivation. When we have immune dysregulation, we see both hyperimmunity or autoimmunity happening, as well as suppressed immunity in certain sectors. We see changes in the gut microbiome, which affects the gut-brain axis and metabolic regulations. We see in studies, which are not available for regular clinical use, microclots happening nearly in all long COVID patients. Neuronal inflammation is a big part. We've seen in lab studies both fusion of neurons happening and syncytia formation between the neurons and between neurons and the supporting structural mitochondrial cells. Mitochondrial dysfunction is a significant concern, so energy metabolism is really affected there, and Jen will speak at a greater depth about that. The kind of symptoms you see, so there's 203 symptoms of long COVID affecting pretty much every body system. And so this is just a really small, quick summary of the most common ones we see. The pink highlights the symptoms people come to you for, like chest pain or palpitations, cough, diabetes. It's going to be energy and fatigue and cognitive impairment. And you also have endocrine and metabolic changes as well. But I also want to highlight for you the box at the top right, which looks at the psychological effects. And so we've known from the beginning that there's a nearly 18% excess risk of new onset psychiatric conditions after a COVID infection. And what we see very early on is mood and anxiety disorders, psychotic disorders, insomnia, and even in severe cases, PTSD. Now, the important thing to recognize is this happens with even COVID infection. It's not simply just a reaction psychologically to distress of COVID or long COVID. It's actually part of the brain effects that we've now understanding that happen with the COVID infection. And so how we look to manage it needs to look at it in a physical as well as psychological support process. Children actually also have a lot of symptoms with long COVID, and this is a review just published a couple of weeks ago. And recognizing there in the list, when you look at mental health, for example, for children, you see things like impulsivity, irritability, you see anxiety, depression, but also attention deficit and hyperactivity, because we know these are some of the brain circuits that are affected. So keep all this in mind as you make a diagnosis. Fatigue and functional limitation is a dramatic cause of disability, with Health Canada estimating about a 10% long-term disability rate from this. Insurance data supports this, that people have a hard time getting back to work. Even if they go back to work, they tend to have reduced hours and need significant accommodations to function. And fatigue was the main driver. And fatigue is up to the level of cancer chemotherapy level of fatigue. The diagnosis, so if you're looking at the working definitions that we have and recognize, this is still something we're clarifying over time. The WHO had a definition that basically talked about what we said here is you typically wait 3 months from onset, but you may have symptoms that are continuing from the beginning and lasting beyond the 3 months, or new onset symptoms or things that relapse. And these are affecting the functioning. We talked about that broad spectrum of symptoms you may see. There's also a pediatric definition of long COVID that's done later on. The key thing I want you to keep in mind, and this is some of the limitations of the working diagnosis, the initial adult diagnosis positioned long COVID as a diagnosis of exclusion when you couldn't label it with something else. But as we see, many of these things already have names, but they definitely are connected to the post-COVID-19 condition. And so you actually may be mislabeling it or not looking wide enough for what you expect to see if you rest on just a diabetes diagnosis or just an anxiety diagnosis. The children's definition was much more clear, that we know that you can have many diagnoses and still have long COVID as well. So I think that's a more practical functioning. The code in Ontario is 081 when you're doing your billing to track it, but recognizing it probably will be underused. And we also know that the post-exertional malaise, the non-restorative sleep, the cognitive impairment that is part of ME/CFS is also something we see oftentimes in long COVID. So 50% of patients with long COVID will also meet the diagnosis for ME/CFS. So with that, I'm going to hand it over now to Jen to take us through the assessment and treatment of long COVID.
Thanks, Javed. So this is a photo of me before, and this is a photo of me after getting COVID, participating in a clinical trial. So what I'm going to go through today, and what I hope you can get out of today, is really that there are like 3 big clusters or phenotypes that really help us understand how to assess people with long COVID, and to get your head around some initial treatments that you can hopefully feel comfortable after the end of this talk, using and prescribing in your practice, and sharing with others. Next slide. This is from an article that came out in the Canadian Journal of Cardiology, led by some of the sort of long COVID experts in our community. And I think it can be a very overwhelming slide, but what I find really helpful is that it outlines these clusters, and that's what I want to get into at this point. So the first grouping, which is one that I did experience, and I continue to experience, is sort of a brutal cocktail of severe fatigue and post-exertional malaise, which Javed was sort of describing. And this is it's so specific. So this isn't just fatigue, and it does feel like cancer-like fatigue. But what people will describe is feeling this deep, dark need to lie down. Symptoms typically start 12 to 48 hours after even minor physical or mental exertion, and it can last for days and less commonly for weeks afterwards. And I think the best analogy, this is fundamentally a problem with mitochondrial function, and the best analogy is to think of it as someone being a cell phone with a low battery. Their battery is always low, and if it runs too low, it needs to be rebooted altogether. So this is a very specific, it isn't fatigue, it's any kind of exertion, whether it's physical or mental, that can result in this sort of delayed severe fatigue. And along with that, you often get this worsening